So once again, I'd like to thank the organisers of the Bain Diabetes and Endocrine Review, the BEDA meeting, for the invitation to speak. And I'm going to give an upgrade or an update on challenges of diabetes diagnosis at presentation, which is based on a talk that I gave to this meeting a couple of years ago. So to begin with, these are my disclosures. So an outline of the presentation. I'm going to give a brief example of the challenge that we face clinically when we're uncertain as to exactly what type of diabetes we may be dealing with. I'm going to talk about the different types of diabetes that are out there, and we are beginning to establish more concrete phenotypes of diabetes than we used to be aware of. I'm going to talk a little bit about the markers that are available, specifically antibodies and also C-peptide, and a little bit about the benefits of recognition, and then a few words at the end about how one might proceed in the complex clinical scenarios that we generally meet. So here's the case. So this is one of my patients who's a 36-year-old lady who's got a body mass index of 27 kilograms per meter squared, and she's been referred to hospital with a capillary glucose of 28 millimoles per litre. She's been complaining of lethargy, increasing thirst and nocturia for about 4 months, and she has no known family history of any forms of diabetes. At the time of review, plasma glucose was 19.5 millimoles per litre, which is approximately 350 milligrams per deciliter. She has plasma ketones of 0.8 millimoles per litre, so not drastically elevated, and her HbA1c is indicating a degree of poor control over preceding weeks or months, with a HbA1c of 10.5%, which is around 91 millimoles per mole. So this is a not unusual case scenario. Back in the old days, we might have thought the age of 40 was an indication. Above the age of 40, type 2, below the age of 40, type 1. I think that's more or less gone out the window with the changing demographic of the various types of diabetes. So it's not quite as simple as it may have been in the past. So diabetes remains a diagnostic umbrella. The two major types of type 1 or insulin dependent diabetes and type 2 or non-insulin dependent diabetes. And I guess in certainly a westernized country, then near on 90% of people would have type 2 diabetes at diagnosis, and near on 10% would have type 1 diabetes. But there are other rarer types of diabetes that there is benefit in recognizing, not only for in terms of treatment, but also for the longevity and the outcomes of the patient. So just to emphasize that this differentiation between type 1 and type 2 diabetes is not new. I think we thought we were reinventing it in the 1980s when genetic predisposition to type 1 through the HLA genes came through, but this has been described previously, and this is an example from the British Medical Journal in 1951 by R.D. Lawrence, who was a UK physician who was the first person in Britain to receive insulin, and then went on to create the British Diabetic Association, or as Diabetes UK, which is a major charity in the UK. So it's something that we've known about, that there are different types of diabetes for an awful long time. So type 1 diabetes, HLA involvement was first identified back in the early 1970s, and we now know that HLA is a major contributor to genetic risk for type 1 diabetes. So HLA, back in the day, DR3, DR4, more recently DQ2, DQ8 are risk factors for type 1 diabetes, and HLA DR DQ2 is actually a protective feature for diabetes, but through massive studies that have been looking at the huge investigations of genetic risk in large populations, we now know there are lots of other genetic markers. I put here over 40, it's a number around there, but unfortunately these genetic markers contribute relatively small amounts of risk for an individual, and as things stand, there is no diagnostic that uses genetic markers that we can apply in the clinic. So when I see people with presumed type 1 diabetes, I'm certainly not sending off their human genome to be assessed for genetic risk markers for type 1. A, it would be relatively expensive. B, it would take some time to come back and wouldn't influence my treatment. And finally, it really isn't differentiating sufficiently. However, antibodies are certainly getting to be a more important part of the diagnostic armamentarium for individuals with diabetes. So we have islet cell antibodies that have been known since back in the 1970s, but I've underlined here anti-glutamic acid decarboxylase antibodies. That's the anti-GAD antibodies, are certainly a well-known and relatively widely available aspect of antibody assessment. More recently, we've got IAA, insulin autoantibodies, and IA2A antibodies, which now would form part of a triple antibody test that is becoming available in many labs and indeed would be a standard for clinical trials looking at individuals with type 1 diabetes or at risk of type 1 diabetes in terms of prevention. And these trials are beginning to become more frequent now as we see immunotherapies that are proven to be beneficial and popular in other autoimmune diseases beginning to infiltrate in the type 1 diabetes sphere. So this has led to staging of type 1 diabetes. Diabetes at diagnosis, which is what most of us would be familiar with, is now known as stage 3 diabetes, and indeed if people have had the condition for a long period of time, it gets labeled stage 4 type 1 diabetes. And here you can see that beta cell autoimmunity, meaning the presence of autoantibodies, is a given for this condition, but these individuals got beta cell loss because the condition has been going on for some undeterminate length of time. They will be hyperglycemic and they will be symptomatic, and these are the individuals who need to have insulin. However, there are now these stage 1 and stage 2 are recognized, and note that they're both defined according to antibodies. So the antibodies I've just mentioned, you'd expect to be present in stage 1. These would, for example, be first-degree relatives of people with known type 1 diabetes. However, at that stage, they have no evidence of dysglycemia, so normal glucose tolerance, and obviously they have no symptoms because they don't have hyperglycemia. The stage 2, which is the individuals who I think are going to be the focus and are indeed the focus of clinical trials to try and prevent or reduce the beta cell loss for patients with type 1 diabetes. They have a degree of dysglycemia, and for clinical trials, these are identified, the dysglycemia is identified by means of a glucose tolerance test. So these are the people who have got the antibodies. They are going down the slippery slope towards significant hyperglycemia, but not at that point sufficient to cause symptoms. And the hope is if you can intervene with immunotherapies such as the new immune therapies coming through, then perhaps you could preserve more beta cell function. And we believe going forwards that is going to lead to a reduction in some of the complications of diabetes, and indeed such phenomenon as hyperglycemia unawareness. The other benefit or utility of antibodies is to make a diagnosis of so-called latent autoimmune diabetes in adults, or LADA. So these are individuals who traditionally would have been diagnosed as having type 2 diabetes because they develop their dysglycemia in middle and later years. But these are the individuals who would not respond well to the glucose lowering effects of metformin, sulfonylureas, and other oral glucose lowering therapies. In general, they tend to be younger and leaner. The UK PDS study, which was a type 2 diabetes study, eventually did anti-GAD antibody tests on its individual recruits and found that the younger and leaner ones who progressed to insulin often had presence of antibodies. So a study that was a research study focusing on people thought to have type 2 diabetes had a proportion of individuals within it who actually had type 1, and the antibodies that typically have been tested are the anti-GAD antibodies. So this is a way of differentiating those people who are very likely to ultimately need to go onto insulin, rather than being presented with this cascade of failure, if you like, in that they're told that diet will sort out their glucose levels, then metformin, then sulfonylureas, then whatever other treatments, and ultimately they just get worse and worse and end up on insulin. So this is a way of predicting that likely outcome. Now, C-peptide, there's a lot of interest in C-peptide levels testing, both urine and serum, and this has largely come about because of the Modi interest in this condition. And the idea here is that you can differentiate those people with type 1 versus those treated with insulin who don't have type 1 diabetes by virtue of their C-peptide levels. But I think the really crucial element in this algorithm that's been produced in Wales by the Welsh Endocrine and Diabetes Society is this central part here about the duration after diagnosis. So there needs to be a prolonged period, which I think needs to be at least 3 years from diagnosis before C-peptide can begin to guide you into whether they are likely to have type 1, in which case C-peptide levels are low, or where they're likely to have some form of type 2 diabetes where C-peptide, i.e. insulin production, is high. And I think it's important to realize that there is little or no utility in doing C-peptide testing at the point of diagnosis. And so this is a test that is held in reserve, meaning that when you see people in clinic and they are treated with insulin, it's important to forever be bearing in mind the possibility that the diagnosis at the point when they were first seen may not be fully substantiated. And that's certainly the case in those people who are antibody negative. Now, I've talked about antibody positivity being a way of staging type 1 diabetes, but it still appears to be the case that at diagnosis, taking any single antibody, such as anti-GAD antibodies, anything up to 20% of individuals would be negative for the antibody at that point. So they could still have type 1, but it hasn't been confirmed. And for these, perhaps C-peptide is an important test down the line, but not at the point of diagnosis. Just to show you that this is a paper published, I think, about 3 years ago now, that is suggesting we can take these phenotypes of type 2 diabetes much further than we currently do. So this was a group that was validating a subtyping of type 2 diabetes, suggesting that in the general type 2 diabetes population, you've got those who are severely insulin deficient. I think those we regard as a sort of thinner, rather high glucose level population. You've got a group that are severely insulin resistant, that may or may not be grossly obese. Those with mild obesity related diabetes, those with mild obesity with high HDL cholesterol, and then a group labeled mild diabetes. At the moment, I don't think this is really impacting or permeating into clinical care, but I guess it's the way things are moving in the future to try and tailor the therapies towards the individual's underlying diabetes diagnosis. So, what about other types of diabetes? This is a family tree of a cohort we collected as part of a type 1 diabetes study that turned out not to have type 1 with dominant transmission. So here you see that not only are there 4 siblings in the same family group that have got the condition, but also an affected parent and indeed an affected grandparent. And this fits with the idea of a dominant, autosomal dominant transmitted diabetes. And this is generally goes under the term of maturity onset diabetes of the young, or MODY. So this is looking at classifying MODY according to the underlying genetic mutation or mutation of the individual genes, and you can see that there are now 11 MODY genes that have been recognized, but I'm just pointing out by the ones in red here that the MODY 7 through to 11 are pretty rare, and you can see that most of the descriptions here talk about very rare medical condition, rare, less than 1% of cases, very rare. So these are not the sort of things that you will see or that will pop up on genetic testing, but there's no doubt that MODY has been the area of diabetes in which genetic testing has been the most effective in making a difference to diagnosis. I've classified here MODY 1 to 5 that probably account in European populations at least for 80% of the cases. At the top here, MODY 2. MODY 2 is at the top because glucokinase was the first MODY gene to be identified. And then the MODY 3, 1, 4, and 5, again based on MODY 1 being the first pedigree to be identified back in King's College Hospital many years ago. These are so-called transcription factor MODYs that tend to be a bit different. Now, I guess the unfortunate thing about all of these MODY genes is that as yet they haven't really facilitated new therapies related to that knowledge, which was one of the major reasons for doing the genetic analyses and investigations in the first place. So, for example, MODY, glucokinase MODY, that leads to a very mild, non-progressive hyperglycemia, most clinically relevant during pregnancy, when the insulin resistance of the pregnant state pushes up glucose levels. And in the past, these patients would automatically go on to insulin, and indeed many of them remained on insulin for the rest of their lives on the basis that they had type 1 diabetes. Well, we now know that certainly that is something that can be revised after the pregnancy is completed. But unfortunately, drugs that have been activators of glucokinase have not really been of any clinical utility. They tend to have a very transient impact. So over time, their effect on glucose levels diminishes, and there's also an adverse impact on lipid profiles that are provoking a more atherogenic lipid profile, which on the basis of a very mild hyperglycemia is not worth the risk that's associated. In comparison, some of the transcription factor MODYs in the past looked extremely like type 1 diabetes, and some of them will still require insulin, but this is a pedigree that we have in my area of Wales, not my hospital catchment. These are rare pedigrees that we find, but you can see that this individual diagnosed at the age of 13, which was the proband, would generally have gone on to insulin and been regarded as having type 1 diabetes for the rest of their life. But the knowledge that there was this strong family history of diabetes, and that the parent and indeed the sibling had been treated without insulin, gave a hint that there was something different going on here, and genetic testing led to the definition or diagnosis of HNF1 alpha, and the patient remains on gliclazide 10 years after that initial diagnosis. So for the rare pedigrees in which you can identify a MODY gene, it can have an impact on their long-term therapy and avoid the need for insulin. And there are certainly examples of individuals from these pedigrees who have received long duration insulin and have had awful control, and yet when they go on to oral therapies, can get much better control. This is another pedigree where diabetes, there's lots of it. It looks dominant, but there's something slightly strange about this. Plus, there are comorbidities going with the diabetes, which are not typically seen. In this specific case, it's the co-association of deafness. And those of you particularly astute in looking at this pedigree will notice that it's only been transmitted through the female line. And this is an example of diabetes due to mitochondrial mutations. And once again, extremely rare, but if it can be diagnosed, then it may have utility. Commonest cause of mitochondrial diabetes is a point mutation in the 3243 nucleotide. Interestingly, mitochondria have their own DNA, which is only transmitted through the maternal line, hence this form of diabetes inheritance. And there is the association here with deafness, but also with more severe neurological conditions. The difficulty in terms of prognostication with mitochondrial diabetes is that the impact in terms of glucose dysglycemia depends on the amount of mutation in different organs. So if there's a lot of the mitochondrial mutation in the pancreas, then severe glucose intolerance can be manifest. But if there isn't very much of it there, which appears to be a random process, then the individuals may have mild diabetes only requiring diet intervention. So the association between the genotype and the phenotype is not strong, and this is even within the same pedigree. So here the utility of knowing about it is less, but if you have a young individual who's thought to have type 1 diabetes on the basis of their age at diagnosis, and I've certainly come across pedigrees like this, then the knowledge that there is something not right as far as their type 1 diabetes diagnosis is concerned can be useful, leading to oral therapy treatment. Permanent neonatal diabetes of the young. This is diabetes within the first 3 months of life, which was formerly a lifelong diagnosis requiring insulin treatment. It's now known that specific mutations in the KERS6.2 receptor are responsible, and very elegant genetic analyses have led to the identification that this transporter or channel could actually be manipulated by using sulfonylureas, which obviously are an oral therapy. And so there are, albeit small numbers of people, because these pedigrees are extremely rare, but small numbers of people who have gone from insulin onto sulfonylureas. And the important thing is that this benefit or response to sulfonylurea appears to be long-standing. So this is a publication from the Lancet Diabetes Endocrinology in 2018, looking at individuals who've been diagnosed 10 years earlier and showing that the oral sulfonylurea treatment remained beneficial. Monogenic diabetes, so this is where the MODY and the neonatal diabetes come in. There are now key features that are giving a good hint about whether these syndromes may be the case, and here's a few that I put down here. So diagnosis less than the age of 25 years in at least one, but ideally two family members, and this multiple generational effect. So the diabetes coming through families. There should be no evidence of insulin resistance. So these are beta cell deficits. So acanthosis nigricans, albeit a rare clinical sign, shouldn't be seen. And then C-peptide here, I'd written ideally 5 years after diagnosis, but certainly after 3 years of diagnosis should still be present in the majority of these cases, and this shouldn't usually be treated with insulin, albeit that there are MODY pedigrees that do require insulin going forwards. Neonatal diabetes, a arbitrary cutoff of 6 months seen, and then there is one of the Modi syndromes associated with renal cysts and diabetes together, which often has got a dominant renal history. And these cases are often picked up in the nephrology clinic rather than in the diabetes clinic. So just to finish with our case, what do we think is going on here? Well, could it be a rare form of diabetes? An issue here is lack of family history. So we would expect for most of these rarer forms that we would see diabetes going into the parental or from the parental and the grandparental generations, but often family history is absent because people may not know, or for example, it could be a novel mutation. So family history isn't a complete exclusion of the rarer forms. Ketones, this patient is not ketotic, which is pushing away from type 1 diabetes, as would her weight. We're not told about weight loss in the scenario, but at the moment she's certainly not underweight. Note that even ketones are not completely diagnostic. We now see ketones as a manifestation in type 2 diabetes related to SGLT2 inhibitors, but for many years it's been well recognized that individuals, especially from an African Caribbean background, can have quite marked ketoacidosis at the time of diagnosis, but ultimately not have type 1 diabetes and remain on non-insulin therapies. Utility of antibodies, I think antibodies are coming more to a fore, but this is not for most of us at least, it's not a immediate test that's available. So it often can take days or weeks, or in some cases even months, for antibodies to come back. So awaiting antibody testing should not be influencing the early or immediate treatment of these individuals. And if you're getting antibodies because you seriously think someone's got type 1 diabetes, then I would suggest you should be treating them as type 1 until the antibody test comes back. And then I've mentioned already the utility of C-peptide getting to be a more commonly used clinical assessment, but really of little value at the time of diagnosis, because C-peptide levels can be high even in individuals with type 1 diabetes and low in those with glucose toxicity because of high glucose levels in type 2. So it needs to be at least 3 years down the line before it begins to give you some real direction. But I guess the whole point of this talk should be that insulin is never wrong. So insulin always gives the clinician and indeed the patient the option of a safe period of reflection. You can always stop insulin after you've started it, but if you don't start it in somebody who actually has type 1 diabetes or is ketosis prone, then that ultimately can be a very bad and indeed fatal outcome for patients. So insulin is always the treatment that should be the default if you really feel you don't know what's going on and you're concerned. Just to finish, my comment about always being aware that the diagnosis should be reviewed. This is a publication in the British Medical Journal in 1983 from Scotland, and in the UK for many years patients have received medals for long duration of diabetes. 50-year medal is the Nabarro medal, and this was an individual who'd been on insulin for 50 years and received that medal, and then somebody in clinic thought maybe they didn't need the insulin and they were able to come off it and be treated with oral medication. So this was 50 years of unnecessary insulin treatment. Bear that in mind with every patient you see, that the diagnosis should always be being challenged. So I shall stop at that point. Many thanks for your attention, and it's been a pleasure to attend this meeting once again.